My name is Dr. Nathan Wong, Professor and Director of the Heart Disease Prevention Program at University of California, Irvine, and I'm here at the International Academy of Cardiology World Congress on Heart Disease talking about the issue of whether diabetes is really a coronary heart disease risk equivalent. So ever since Steve Hafner's publication of the East-West cohort 15 years ago, which showed that people with diabetes but no prior myocardial infarction had a similar prognosis as those with a prior MI but no diabetes. This has really led to the concept of diabetes as a coronary heart disease risk equivalent. And in 2001, the Adult Treatment Panel 3 of the National Cholesterol Education Program designated diabetes as a coronary heart disease risk equivalent. However, since that time, this concept has been brought into question, and there have been a number of editorials and reviews which have really pointed out that perhaps diabetes is not always a coronary heart disease risk equivalent. And in fact, there was a meta-analysis published about 5 years ago in nearly 40,000 individuals who had diabetes. And basically, overall, there was a 43% lower risk of future coronary heart disease events in persons with diabetes but no prior myocardial infarction compared to those with an MI but no prior diabetes. So this has really helped illustrate the issue that we really need to consider individualized cardiovascular risk assessment in people who have diabetes. And there are also numerous factors that interplay into whether diabetes is really a coronary heart disease risk equivalent. So certainly it's not surprising, and we have published data from the National Health and Nutrition Examination Survey showing that the vast majority of younger persons under age 40 who have diabetes are actually at lower risk, and conversely, older persons with diabetes are at much higher risk. Also, those who are insulin treated are at higher risk than those that are not insulin treated. There have also been several reports recently that have suggested that women who have diabetes may be more likely to be a CHD risk equivalent than perhaps men who have diabetes. So there appears to be a gender difference, and in particular when we're talking about fatal cardiovascular events. And finally, there's the issue of the impact on subclinical atherosclerotic burden. So we have published data from the multi-ethnic study of atherosclerosis, for example, showing that individuals who have calcium scores of 400 or more are at 10 times the risk as those who have calcium scores of 0 among people who have diabetes. And that's about a third of persons with diabetes actually have a calcium score of 0 and are at actually much lower risk than many people who don't have diabetes. So really the extent of subclinical atherosclerosis burden is also a very strong determinant as to whether diabetes is really going to be a coronary heart disease risk equivalent. So I think in conclusion, it's not a simple answer, but we know that diabetes is certainly not universally a CHD risk equivalent, but it really depends on a lot of factors such as perhaps gender, extent of subclinical atherosclerotic burden, also duration of diabetes, and And really because of this, it's very important that we consider an individualized approach towards risk estimation and management of persons with diabetes, so we can really more aggressively target those who are at highest risk.